This is one such image where if these subungual growths are found, then the answer would be Koenen's tumor. So you should be in a position to identify this very important finding, which you get to see in the disease called as tuberous sclerosis. It is a genodermatosis. It is also called as Bonwell's disease. It is an autosomal dominant condition which has two possibilities due to the different chromosome abnormalities. If the defect is in the chromosome 9, then it is tuberous sclerosis type 1, and if the defect is in the chromosome number 16, then it is tuberous sclerosis type 2. And it has a triad of epilepsy, low IQ, and adenoma sedation. So these three form the Vox triad. So always remember, tuberous sclerosis, it's a genodermatosis, and to diagnose this, there are certain major features, out of which I have mentioned two of them here, that is adenoma sebaceum and Sjogren patch. And remember, adenoma sebaceum is the characteristic finding seen in tuberous sclerosis. So what will be there is, you can see there are multiple grouped papules which are present over the face with involvement of cheeks and also the nose and also involvement of nasolabial folds. So actually adenoma sebaceum name is a misnomer, because these are actually on histopathology you will get to see blood vessels and fibrous tissue. So that's why these are referred now as angiofibromas. So adenoma sebaceum or angiofibromas are one and the same, and remember, it is the characteristic feature of tuberous sclerosis. And the next finding is Sjogren patch. So these are present in the lumbosacral areas. Here you can see this is the lumbosacral area. These skin colored pudy orange appearing plaques. See, this is also one more misnomer. It is actually not a patch. It is a raised lesion, so it should be actually called as a plaque, but it is named as a patch, so it is a misnomer. These can be seen in the lumbosacral area. So what will happen if you are a dermatologist, then the pediatrician will call you for the presence of these whitish lesions to differentiate it from vitiligo. So because these changes are the most common skin manifestations in tuberous sclerosis. Okay, and also these are the earliest finding. What they are called as ash leaf macules. So if you see these lesions over the body of the child, then you should search for whether Sjogren patch is present or not, and also you should examine the fingers, toes for presence of the Koenen's tumors. Koenen's tumors are also called as periangular fibromas. And there are certain other minor features which are seen in tuberous sclerosis. They are confetti macules, and there will be gingival fibromas, and there are dental enamel pits. So all these findings you should be in a position to identify. So coming to the next condition, this is a question related to psoriasis. It's a sign which is elicited. So the examiner is asking whether it is punctate bleeding spots from the hypopigmented halo around the plaques, or whether it is from the elongated capillary loops, or it is from the spots only at the sites of trauma. So if you think it is B, then you are correct, because these are, see, I will just tell you briefly. We'll take a glass slide and we will do grattage, and we will remove the scales. After scales are removed, we get a whitish bulkless membrane, and if you remove the bulkless membrane further, then you will get to see pinpoint bleeding. This bleeding which we see clinically is because of the histopathological characteristic finding, which is termed as suprapapillary thinning. I will explain what this term means, but you remember it is called suprapapillary thinning. So can you appreciate this as a papilla? Okay, so these red structures here are blood in the blood vessels. So usually papilla have blood vessels, but in case of psoriasis, there will be dilatation of the capillaries. And as you can see, the distance between this papilla and this has been reduced. So this is termed as suprapapillary thinning. And also, if this is, since this is psoriasis, you can also appreciate that these stratum corneum cells are having the nucleus. So this feature which is seen in psoriasis, that is retention of the nucleus in the stratum corneum, is called as parakeratosis. Okay, this was important finding. So once again, a repetition, auspitz sign which we see clinically is because of the histopathological changes of elongation of the double blood vessels and suprapapillary thinning. Okay, so let us move on to the next question. So identify this lesion. So whenever you get an image which is depicting these kind of lesions which are having a central erythema, pallor surrounding that, and again a surrounding erythemas, that means three zones are clearly visible in these in this image. So the diagnosis will straight away go to erythema multiforme, and these lesions are the characteristic special lesions which are called as target lesions or iris lesions. These are also called iris or target lesions. So as I've already told, it has three zones. The central dusky zone can have papule or a vesicle or bulla. So this is the central dusky zone, which is followed by an intermediate edematous pale zone. As you can see, this is slightly paler when compared to the central erythematous zone. And there is yet another zone which is erythematous. As you can see here, this is the erythematous rim. So if these three zones are present completely, then we will call it a perfect target lesion, and it is characteristic for erythema multiforme. But if there are only two zones, then you will call it as targetoid, and this is characteristic for Stevens-Johnson syndrome and toxic epidermal necrosis. Even these are important image-based questions. I will try to cover these in the following upcoming videos in the future. So to get the updates or the notifications of these videos, please do subscribe to the Unacademy NEETPG Live YouTube channel. So okay, the erythema multiforme. So what are the etiological causative agents for the erythema multiforme? There are innumerable causes, but you should remember that what is the most common cause. The most common cause is always difficult to find out. It is idiopathic. Otherwise, if the question says what is the most common infection which will lead to erythema multiforme, then here the answer will become herpes simplex virus. More than any other infection. The other infections can be bacterial, they can be mycobacterial, they can be plasmodium related, but the most common cause is a virus, and it is herpes simplex virus type 1. And drugs, usually drugs will cause SJS and TEN, but also remember, even erythema multiforme can develop secondary to the intake of the drugs. The most important drugs which you need to remember are non-steroidal anti-inflammatory drugs, sulfur-related drugs, sulfonamides, and anti-malarials. So please do remember all these causes of erythema multiforme. So the next question, please identify this lesion which is present over the prepuce, under surface of the prepuce. So, and these are the options. And I can see that many students have a confusion between Fordyce disease or Fordyce spots. So here we are talking about, these are asymptomatic yellow appearing dots, and these are called as Fordyce spots. Okay, so briefly I will explain. Usually the sebaceous glands, they are associated with hair follicles, and if they are not associated with hair follicles, and if they open directly onto the skin surface without a relationship with the hair follicle, then we will call it as ectopic sebaceous glands. Okay, so there are various types of ectopic sebaceous glands, and we have given different names for them. So here in this case, Fordyce spots is one of the name. When we see sebaceous gland opening into the upper lips or buccal mucosa or tongue or penile shaft, and mind you, Fordyce spots, the most common site is the upper lip. These are completely asymptomatic, and you need not treat them. You can just explain the patient that they are absolutely normal and there is no intervention needed to be taken. And there is, if the Fordyce spots are present over the undersurface of the prepuce, then they are given a special name which you should remember. They are called as Tyson glands. So yet other modified sebaceous glands, examples are Montgomery tubercles which are present over the breast. Here you can see over the areola near the nipples, and Tyson glands have already told. And if they are present on the eyelids, they are given the name of Meibomian and Zeiss glands. Okay, so please do identify these hair changes. It is called as an exclamation mark hair, and this is a very characteristic question, very characteristic finding, and this question has been asked innumerable times. So you must be in a position to answer this question straight away as alopecia areata. Why is it called exclamation mark hair? As you can see, the most proximal part of the hair is extremely thin, and the distal most part is having bulge. That is, it is slightly thicker when compared to the proximal hair. So why does this happen? There is histopathological reason behind this finding, this clinical finding. So I will briefly tell you about alopecia areata. It is an autoimmune disorder of the anagen hair bulb. See, anagen is the active phase of the hair cycle. So alopecia areata affects these hair follicles, and on histopathological examination, what you can see is there is peribulbar, that is at the proximal most part of the hair follicle. We'll call it as a bulb, and there will be T lymphocytic infiltrate present in the peribulbar area. That is, our body will recognize our own hair follicle cells as foreign, and our own immunity will mount immunity against the hair follicles. So these lymphocytes, which are present peribulbar location, on histopathology, they will appear like a swarm of bees which are going to the hives. So this is given the characteristic name of swarm of bees appearance. So that was about the clinical finding and histopathological finding. So when the patient of alopecia areata comes to you for treatment and management, then you should be in a position to explain the patient about the possible prognosis. That is, whether there will be a possibility of hair regrowth or whether the condition will deteriorate and all the hair will be lost. You should be in a position to answer these queries of the patient. So if the alopecia areata is early in the age of onset, and if there is involvement of complete scalp with patches of hair loss, and if there is whole body which is devoid of hair, that is alopecia universalis, it is scalp, it is called totalis. And if there are other autoimmune diseases like there can be association of diabetes mellitus. So if And these conditions are, along with atopy, if any of these are present, then you can say that the patient has a very bad prognosis. That is, there is every possibility that hair might not grow back, and also there can be even extension of the patches to a more extensive areas. That is, it can involve the entire scalp or even entire body hair can shed off. So if the alopecia areata is only localized, then the treatment of choice is intralesional steroids. So what we'll do is we will give intralesional steroids. But if the condition is extensive, then we have to give systemic steroids. So why are we preferring steroids in this case? Is because our immune system is mounting immunity, autoimmunity against the hair follicle. So we need to reduce the T lymphocytic infiltrate near the peribulbar sites. So to reduce the T lymphocytes, we make use of the steroids. So we make use of the steroids which have anti-inflammatory activity and reduce the lymphocytic infiltrate around the peribulbar area. And we try to treat the alopecia areata with the help of steroids. Either it can be intralesional or it can be oral or